Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ardellix.
Hello, Chicago. Welcome, welcome, welcome. We are so thrilled that you could all join us on this gorgeous Monday morning. We're actually Monday morning here in the Windy City. On behalf of Medscape, I'd like to officially welcome you to our Medscape Live News Report. Today's breaking news is all about IBS-C. My name is Taryn Winter-Brill. I will be your host, moderator, and roving reporter for tonight's program. More about the roving reporter segment. That's going to be a lot of fun. What I would like to do now, though, is cue you up for another video. It's about 2 minutes. This video is terrific because it's really going to give us a roadmap into the conversation that we're all going to be delving into over the course of the next 75 minutes. And since this is a breaking news report, it's supposed to feel like a new studio with the light. Let's pretend we're in the control room. If we were in the control room, we would yell, "Roll it."
Welcome to Breaking News in IBS-C, expert insights, patient voices, and challenging cases. Today, we bring you the latest information and expert perspectives to help you optimize treatment for your patients with irritable bowel syndrome with constipation, IBS-C. IBS is one of the most common disorders of gut-brain interaction experienced by individuals worldwide, and IBS-C affects roughly 10 million Americans. Despite its high prevalence, IBS-C can be challenging to diagnose, even for experienced clinicians. Symptoms are often vague and nonspecific and can overlap with several other common gastrointestinal disorders, including other forms of chronic constipation. Many patients with IBS-C suffer for years and see multiple providers before receiving a definitive diagnosis. And we'll hear from one such patient with IBS-C who will describe her diagnostic journey. There are now 4 FDA-approved drugs specifically indicated to treat IBS-C. These agents can provide substantial relief for patients, but are often underutilized as patients cycle through a variety of over-the-counter medications and dietary interventions before advancing to a prescription treatment. In today's symposium, our expert panel will discuss best practices and provide real-world insights into the diagnosis and management of IBS-C, including a review of the new Rome 5 diagnostic criteria. We'll hear which OTC therapies, diets, and lifestyle interventions are effective for treating IBS-C and which are more hype than reality. Stay with us as we navigate these critical topics together to enhance the management of IBS-C and find out if your practice aligns with the most up-to-date recommendations. Let's advance patient care together.
All All right, let's advance patient care together. We can't do it without the help of, I think the video called you an expert panel. I'm calling you an all-star panel. So it is time to meet our all-star panel. Let's start with Dr. Brenner. Please kindly introduce yourself.
Thanks, Taryn. You're too kind. So welcome, ladies and gentlemen. My name is Darren Brenner, and I'm a professor of medicine and surgery here at Northwestern University in Chicago, and I run our neurogastromotility division.
I'm Baha Moshri. I live in Charlotte, North Carolina, and I'm director of motility there, and I'm a professor at Wake Forest University School of Medicine that's in Charlotte now.
I'm in Charleston, South Carolina. I'm a professor of gastroenterology and medicine in the Division of Gastroenterology.
All right, well, welcome to you all. We are so thrilled to have you. We cannot wait to dive in. Everybody, we have the agenda up. You'll see it in a moment. This is kind of, once again, the roadmap, all the segments that we'll be delving into and what you can expect over the course of today's program. You'll notice, you see the roving reporter taking it to the streets. There's 2 of those segments. So this is a lot of fun. This is what I mentioned earlier. What this means is throughout the program, twice to be exact, I will be leaving the stage and joining you all. And I'll be presenting you with a very lighthearted question about some of the material that we've been discussing. And it's really terrific because it's a chance to get your perspective, your insight, your commentary, your feedback. I like to say your lived experience as a clinician. But more importantly, what it does is it establishes a dialogue between you all and our terrific panel, and we get a conversation going. Today's all about being educational and didactic. We're here to learn new things, breaking news, but it's all about being interactive, and that's where you all come in. We're going to toss the mic to Dr. Brenner, and that's the proverbial toss. I won't be tossing a mic to you. If I had one now, maybe I would.
Thank you very much.
You're welcome.
So let's talk a little bit about irritable bowel syndrome with constipation and why it should be on your radar. And obviously, we're all practicing gastroenterologists, or at least within the field of gastroenterology. And I always say, if you don't see a patient with IBS and you practice GI, there's probably an issue. So there's an obvious reason why we're all here this evening. And we know that IBS is very common. You know, the previous video just said that it impacts about 10 million people. That's IBS-C. Realistically, if we use less stringent clinically based criteria, we say anywhere between 10 to 12% of the US population has irritable bowel syndrome, which is more in the 45 million person range. Now think about that, right? Let's break the numbers down, 1 in 8 to 1 in 10. So I trained in Ann Arbor. I'm a University of Michigan guy, and I spent many a Saturday afternoon in the big house that holds 116,000 people. And so I would look around, and I'm a nerd, so I'd say, I wonder how many of these people have irritable bowel syndrome, because there was a fellow there. And think about that. If there's 116,000 people in that stadium, how far do you think I have to look to identify an individual with IBS, or case in point? I think there's about 60 or 70 of us in the room right now. So that means at least somewhere between 6 and 10 of us have IBS. So who's going to admit it? Nobody.
No, you got one over here.
Oh, one. Thank you. You know, it'd be nice if this was an IBS-D lecture, because we all know about the postprandial urgency. And as people ran out of the room, I'd be able to pick you off with the laser on the pointer. But it's more constipation tonight. So that's what we'll go over. Now, if you look at the old PRO data from patients, we think that the prevalence of IBS-C, D, and M is about the same. A third, a third, and a third. But I really like to stop here and focus a little bit, because I actually think that the IBS-M group is basically a prevalence rate that is higher than what we normally see. And that occurs for a couple of reasons. I think actually a lot of these people more so meet the criteria for irritable bowel syndrome with constipation. And so I want to talk to a couple of scenarios on how these people present. So scenario number 1, they come in and they say, Darren, I don't have a bowel movement for 3, 4, 5 days. And then I get the urge to go to the bathroom, and I pass some Bristol 1 or Bristol 2 stools. And once I get out those really hard chunks, then they get softer and softer and softer. They go to diarrhea. I have 6, 8, 10 bowel movements. Then I'm completely evacuated. I start the process over again. That's IBS-C with overflow. That's not a mixed subtype. The other one is the patient who walks in your office and says, I alternate between constipation and diarrhea, and you pull up in their chart, and they're taking 3 or 4 different laxatives. And you say, well, I think the diarrhea is related to the laxatives. What would happen if I took these medications away? And they look at me like I'm crazy, and they say, oh, please don't, because I would never go to the bathroom again. So remember, when you're subtyping these individuals, it's based on them de novo without therapeutics on board. When we ask patients to tell us what their subtype is, they don't realize this, and it does skew those statistics a little bit. So again, I think IBS-C is a little bit more prevalent than IBS-M. Now, what's the problem with IBS? I don't think IBS is a single entity. As a matter of fact, in my slides, I usually have a slide that says IBS is IBSSSSS. multiple etiopathogenic mechanisms that cause the exact same symptom profile. And on this slide, we are showing you all kinds of different mechanisms that we think are in play. Now, on the IBS-D side, we've done a little bit better job identifying some of these. We really aren't there yet with IBS-C. But the point is this. If we want to do better by our patients, it's not all about treating the symptoms. We've gotten very good in 2026 at treating symptoms. Like the video said, we have 4 FDA-approved therapies. But realistically, if we want to do better and drop our numbers needed to treat, we have to identify the underlying cause of the symptoms, come up with an appropriate diagnostic test, and then treat the cause, not the symptoms themselves. And we all know that irritable bowel syndrome is a biopsychosocial disorder, right? It's not IBS equals IBS. I think I have IBS, I meet Rome 5 criteria, I have irritable bowel syndrome. As I just mentioned, there are multiple mechanisms, but then there are the biopsychosocial components, right? Anxiety, stress, overlapping disorders, acute events that occur that modulate or mediate the symptom profile that the patient experiences. So it's much more difficult to define this disorder than just using the criteria, although they are beneficial at making that initial diagnosis. And that is where we want to start. Because the reality of the situation is that it takes us way too long as practitioners to make this diagnosis of irritable bowel syndrome. The old AGA IBS in America study showed that the average individual will wait 4 to 5 years, see 4 to 5 practitioners before the diagnosis is made. More than 10% of individuals will wait more than a decade, and 3/4 of people in the United States who would meet criteria for irritable bowel syndrome remain undiagnosed, okay? Another problem we have. The vast majority of practitioners think IBS is a diagnosis of exclusion. It's about 75% of practicing gastroenterologists and about 80% of practicing primary care practitioners. So run a bunch of tests, superfluous tests, we'll come back to that a little bit later, and then say, I think it's irritable bowel syndrome. Or on the flip side, a young person comes into the office, they have a little bit of bloating, discomfort, some intermittent constipation, call it IBS, and it sticks forever. We have to get better at making a concrete, definitive diagnosis, and it turns out that it's very, very easy to do, and I think Dr. Sharma is going to cover that in a few slides. And the reason why we have to get there quickly is because this is a disorder with a major burden of illness that significantly impacts quality of life. Not a day goes by in my clinical practice where somebody doesn't come in and say, I was told it was a nuisance, or it's all in my head, or just learn to live with it. But that is the impression that we give our patients, is not the impression that our patients give us. And so what I'm showing you on this slide is 2 different studies that really hit home on how patients experience and what these symptoms mean to them. So on the left is a study that came from Sarah Ballou's lab. She's the head of behavioral psychology at Harvard. She did a study where she said, I have the ability to take away your IBS symptoms for 1 month. What would you be willing to give up for that relief for 1 month? Now, about 2/3 of individuals said they'd give up alcohol, okay? More than half said caffeine. That would be very hard for me. 1 out of every 2.5 individuals said they would give up sex. I'm not going to touch that with a 10-foot pole. But the reality of the situation is, look at the top 2. They may be the lowest percentages, the internet and the cell phone, but that's 1 out of every 4 to 5 individuals. Now, think about the last time you looked at your cell phone or you pulled up the internet today. And then think about who gets diagnosed with this disorder, right? Young individuals, they're teens, 20s, maybe 30s. I have 2 19-year-old daughters. From the moment they wake up to the minute they go to sleep at night, they are on that thing. And I know that for a fact because I get their weekly summaries every week. Case in point, my cousin a couple of years ago, I was having dinner with my cousins. They were talking about their daughter. They're like, she's never off her phone. Let me prove it. We all know we can do this to our kids. Pulled up the phone, turned the lock on to the internet. Literally 5 seconds later, I hadn't even picked up my fork yet, phone's on fire. Dad, why did you turn off my internet? I didn't do anything. Yeah. So this is a big deal to the people that are diagnosed with IBS, but we all know these as creature comforts. I find this amusing. Cell phone and internet. When I was their age, there was no cell phone or internet. I'm old, okay? So I could give these things up easily. But what hits home even more is what's on the right side of the slide. This comes from a study from Doug Drossman's lab more than a decade ago. Doug took about 2,000 people around the world and said, I've got the Harry Potter Elder Wand, and I'm gonna wave it and say, IBS-O eliminado, and boom, your symptoms are gone for life. And Doug said, would you like that? And of course these individuals said they would like that, right? Why wouldn't you? But Doug said, okay, I want something in return. I want life. So Doug asked, would you give up a portion of your life for a cure for irritable bowel syndrome? And invariably people said yes. So he said, okay, how long? And the average person said they would give a quarter of their life remaining, which was 15 years, for a cure for IBS on the spot. So think to yourselves what a nuisance is. A nuisance for me would be me banging my shin on the edge of this table. It would throb and hurt for a couple of minutes and it would go away. Would I give up 15 years of my life? Absolutely not. So we have to make that diagnosis quickly because we understand the burden of illness, because the patients are telling us what it is, and we got to get to better treatments for those individuals. So now we're going to hear a little bit from a patient.
Hi, my name is Karen. I am a mother of 3 kids. I live in Charleston, South Carolina. I have been living with IBS-C for a very long time. It goes back to 2009. I was a very healthy person at the time and came down with a virus. And what I know now is that I had what is known as post-infectious IBS-C. Predominant symptoms, number one is just probably malaise, abdominal pain and discomfort. I think every IBS patient would say they have some measures of gas and bloating, incomplete evacuation, and it just leaves you feeling disgusting. You really don't want to socialize with people. It really does impact your everyday life because you're not feeling 100%. And what I came to understand is that you have physical symptoms going on in the gut. It really is taking attention in your brain as you're very aware of the pain and the discomfort. I went through so many different tests, so many different procedures, everything under the sun to try to understand what was going on. And after dozens and dozens of doctor's appointments, I still was left without a diagnosis. It's very hard to be a patient in that scenario. I know that every doctor ultimately wanted to try to help me, but I think sometimes the IBS patient, there's a lot of complexity. And oftentimes you feel like you're being dismissed or that you really don't have a problem. Going into a doctor's appointment and talking about something that's very awkward and very uncomfortable, it's really important to listen and just try to understand where the patient is coming from. It took me about 7 years to reach a place where I finally found a doctor that was able to give me an accurate diagnosis. And it wasn't until then that I would say my quality of life began to improve.
Okay. So we're going to take it to the streets. Taryn, what do we got for the audience?
I think my mic, oh, here we are. Thank you. Well, I first just want to say thank you for our patient testimonial. I find it so brave and it's heartfelt. So it's so nice to have somebody really volunteer and share their personal experience. It is time to take it to the streets. Here's our roving reporter segment. We're taking it to the streets of the Marriott Marquis here in downtown Chicago. All right, here's our first question. What questions do you ask your patients with constipation? What questions do you ask your patients with constipation? We'd love to hear from a few of you. I see a hand right over here. Can you stand up for me? Get your name. Thank you so much. Hi, what's your name?
My name is Sahla Haman.
So nice to meet you. I'm Taryn. So what do you think? What are your thoughts to this question?
So I think the main questions we ask from patients who come with constipation is, of course, the bowel frequency, how many times they're going to the bathroom, and then also the consistency of the bowel from the Bristol stool scale, what it looks like. And those are the two main. And of course, then abdominal pain or any nausea or bloating and all those symptoms.
Well, thank you for volunteering. Thank you for starting things off. We appreciate it. Who else would like to volunteer? I thought I saw some hands over here. I think I see a hand. Is that a hand? Is that a pinky or a hand? I'll take a pinky. Hi, sir. Can you stand up for me? I'm Taryn. It's lovely to meet you. What's your name?
Guilherme from São Paulo, Brazil.
Yo hablo español. I don't speak Portuguese, but very similar. Well, I'm going to ask the question in English once again. What questions do you ask your patients with constipation? Maybe you could add on to what our first volunteer had to say.
I think she said the most common questions, but we also ask what triggers their pain and their symptoms, if there is any specific food, any behavior when they are nervous, they have problems in their jobs or in their homes, and if they do physical activity or not, how much water they drink, what they eat. These are the main questions also.
Triggers, lifestyle choices. Thank you so much. We appreciate it. Was there anyone else in this area that wanted to participate? All right, we do have another segment coming up, so I'll look for you then. Doctors, I would love to hear your thoughts about our audience impact, their perspective. It's nice to hear clinicians' real life experience rather, what they're experiencing in the doctor's office. So what do you all think?
So we heard a lot about physical symptoms, abdominal pain, discomfort, constipation, texture of stools, straining, etc. But I think there's another key point that needs to be addressed with these patients that the patient mentioned as well. So what do you think, Dr. Moshri, Dr. Sharma? What else do we need to be asking these patients to develop a baseline?
I mean, I think it was the fact that this patient has other, other issues that are affecting their quality of life, right? So they kind of alluded to the gut-brain interaction issue. They were fatigued, social interactions, right? It's really limiting other aspects of their life. And I think that's something that's really important to address.
Yeah, and then I guess to kind of distinguish how the abdominal pain or constipation gets better when they have a bowel movement, and the frequency changing in their bowel movement. So getting a little bit more nuanced into those kinds of things to kind of get more at the IBS aspect than just the constipation aspect.
I think, it's important to quantify, right? When you get that first baseline, you're meeting that patient for the first time, get some sort of quantification of the pain, the frequency, like you said, the Bristol stool scale, and also quality of life. Because I'll be honest, a lot of times when my patients, send messages on my chart, it's not about whether or not they've gone 3 times a week to the bathroom or if the pain's reduced from a 5 to a 4. It's they got an event or they want to travel or they feel like their spouse is uncomfortable because they just can't go out and have that social life anymore. And so I do try to get a baseline from all of my patients in terms of how it affects them, not only socially, but also from a work perspective, right? If they've got jobs, can they work? Is there absenteeism, presenteeism? Because we need to focus on that as well. Great.
So moving on to the next segment, I'll be taking you through that, the best practices in diagnosing IBS-C. Here we'll start with a case. This is a 34-year-old woman who presents to our clinic. She's married, she's on this seesaw of life. She's got a young child and she's got aging parents with a very stressful sales jobs. She's had 4 years of constipation that have worsened over the last couple of months. Her abdominal discomfort and bloating and incomplete defecation with straining are also things that she volunteers to you. And her symptoms are negatively impacting her job and her home life, so it's really affecting her quality of life. And she's turned down a promotion because she's worried about taking on additional responsibilities. So that's very common. I mean, our patients really can't move in their career with confidence because of symptoms due to IBS-C. So in the next couple of slides, let's go through what information we need to make that diagnosis. So the breaking news for this DDW as well as the symposium is that we've moved on from Rome 4 to Rome 5 diagnostic criteria for IBS. So what are the changes with that? We're now saying that we need to include discomfort in the language. We have gone back to where Rome 3 was to include discomfort. So recurrent abdominal pain or discomfort on average 3 days a month instead of just 1 day a week. So that's another frequency change there. In the past 3 months associated with more than 2 of the following. So related to having bowel movements and defecation, associated with a change in the frequency of stool, and associated with a change in the form of stool. So any of these, 2 of these 3 need to be met. And that criteria, just like similarly before, needs to be fulfilled in the past 3 months for the last 6 months of the onset of the symptoms. So I think this is going to moving towards that positive diagnosis. It becomes more inclusive. That last iteration probably made us less inclusive. So now we're including more patients into this diagnosis that may have been excluded with the previous iteration of Room 4. Moving on to alarm features. What should we worry about with our patients that have these symptoms? So fever, acute or rapidly progressing symptoms with any condition are common. Family history, obviously, of colon cancer, IBD, or celiac. New symptoms and age over 45. And then unintended weight loss. So not GLP-1 induced weight loss like we're seeing all over the place, but unintended weight loss. and how much weight loss. So it's important to quantify that because a little bit of weight loss can be intended and normal in the course of disease, but greater than 10% weight loss over 3 months is what's been shown in studies to be significant as a red flag factor as an alarm feature. And then blood in the stool, unrelated to hemorrhoids, anal fissures, which a digital rectal exam is needed, which we need to kind of incorporate in our clinic in some of the concerning patients. And then iron deficiency anemia as well as an alarm feature in that whole process. And then symptoms that wake patients up at night. So really disturbing alarm feature there if somebody's waking up at night for their constipation and their pain to address. So like we saw in the introductory video, there's a lot of overlap of IBS-C with other disorders of gut-brain interaction. And particularly with IBS-C, as you can see on the slide, a third of patients have 3 conditions: IBS-C, functional dyspepsia, and GERD. And we know that the patients that have all these overlapping symptoms have the most abdominal pain, have the most abdominal discomfort, bloating, and constipation. And the severity of that is also the most severe. Patients have more productivity losses when they have overlapping conditions. And that data isn't shown on the slide, but it's true, and that's why patients will turn down promotions like our case. As we move through thinking about making a diagnosis for IBS, it's important, like Dr. Brenner mentioned, to take a very careful history, not just of the symptoms, but how it impacts their quality of life. Perform a physical exam that's very thorough, including a digital rectal exam, and then applying the symptom-based criteria, just like the new updated Rome 5, to include that in the diagnosis. So that's important for making that diagnosis and then assessing the alarm features that we mentioned on that slide. I like how the alarm features followed making the symptom-based diagnosis because it reminds me that I need to continually look for these alarm features in my patients as they follow up with me. And then if we do find them, do the further testing that's needed. And then classify these appropriate treatments based on the subtypes of their symptoms, whether it's functional constipation or IBS. So here, not all patients require testing is important to take home from this. No role for colonoscopy in all patients. Obviously, if they're age appropriate and need colon cancer screening, it's important to screen them. No role for stool studies in patients with chronic symptoms. Yet there's no good biomarker. And I think this gets back to what Dr. Brenner was mentioning, is we have all these different syndromes potentially and pathophysiologies, and we're working towards identifying these patients a little bit better. And for patients with a positive IBS-C diagnosis, guidelines recommend going straight to treatment. So not wasting time with visits with additional testing. If treatment fails, then we need to assess the pelvic floor. That's the big elephant in the room here. So pelvic floor is what we're talking about is dyssynergic defecation, and dyssynergia is basically a 2-component problem: rectum and anal incoordination. It happens in both sexes, but it's more prevalent in women. Well, why? Well, women go through a lot of things that men don't, right? They have kids, deliver, labor, C-sections, hysterectomies. All that can affect our ability to generate rectal push pressure, which can be overlooked in just a rectal exam sometimes. And then this can be seen, pelvic floor dysfunction can be seen in all types of IBS. A balloon expulsion test, if you have this set up in your office, can be performed. And then some, but not all patients need to go for anorectal manometry for further evaluation and a diagnosis of pelvic floor dysfunction. And then with treatment, we need to refer to our pelvic floor colleagues as well as biofeedback therapy if you can get it and it's available to you to help correct this underlying dysfunction.
Oh, actually, I don't. All right, so now we're gonna move on. Thank you, Amal. That was a really nice overview of what diagnostics we need for these patients. And you heard from the patient cases that these patients can be complex, right? They don't just have one symptom. It's multiple symptoms, other social issues that can be happening. So we're gonna talk about, how do we advance treatment options? And so we start off with the easier approaches and probably the more initial treatments that many of us can offer. So, obviously encouraging hydration. During the summer months, a lot of people get dehydrated. And so you want to encourage that they drink enough water, encourage physical activity. Just a simple recommendation of walking about 20 minutes can be helpful in patients. And as people get older, obviously the pelvic floor gets weak. just naturally from not being as active. So I think being active is a good lesson to tell some of these patients to do. Limit use of medications that can affect and cause constipation, right? So something simple like, for example, diphenhydramine. A lot of patients take antihistamines during the spring or fall, and these medications can constipate, right? They may not know that non-steroidal medicines, NSAIDs, they're very easy culprits. Obviously, opiates, things like that can cause constipation. Diet and fiber. There was a really nice session at the AGA on dietary treatments by Beth Dofer, and she talked about how only 1% of the American diet is made out of fruit. That's sugar, so it's only 1% of our sugar content. Everything else comes from processed foods. So fruits have a high source of fiber, right? Increasing that soluble fiber is really preferred. Things like psyllium is recommended. And individualizing use of over-the-counter medications. Maybe not every patient would want to eat fruit. For example, if they're diabetic and things like that, then you may want to just add the non-sugar fiber supplements, things like that. So it really has to do with what the patient's facing. Now, we've come up with this algorithm here that, we've listed a lot of the treatments that we have, including dietary treatments, over-the-counter therapies, FDA-approved prescription medications, which we'll talk about, the secretagogues, retainagogues, and then brain-gut behavioral therapies such as neuromodulators and even use of apps. And this goes through the AGA clinical practice guidelines. We also have the ACG clinical practice guidelines. They're a little bit different. The ACG clinical practice guidelines, I would say, really looks at the global symptoms that these patients have. So the bloating, the constipation, the abdominal pain, whereas the AGA clinical practice guidelines really looks at that clinically meaningful improvement by about 10%. So there's a little bit of a differences. In general, I would say probiotics, we do not recommend. So there's things we don't recommend. SSRIs, we do not recommend. And otherwise, we start with these lifestyle modifications, and then we go to over-the-counter agents, and then the prescriptions. So physical activity, right? What data do we have? The Red Journal actually published this last year. And the study population was from the NONS database, and it's from 2007 to 2010. 9,000 or over 9,000 adults actually answered this questionnaire. And the exposure was basically the amount of exercise. So are they inactive? Are they insufficiently active, sufficiently active, etc. And what they found was that just engaging in regular exercise activity for 20 to 30 minutes a session, right? Whatever the exercise was. We'll talk about yoga. But that's, effective exercise for patients that have irritable bowel syndrome. Just over 5 days a week can reduce the likelihood of constipation. So again, that's just a very easy intervention that you can tell patients if they're not exercising. So now we'll go to Glinda again, right? 34-year-old woman. She's in the GI office. She has IBS-C. Based on her history, we made a positive diagnosis of this. We limited the tests for this patient. And she tried fiber, so she already tried soluble fiber. And she says she went up to 30 grams a day, which is our recommendation. And she even did a modified low FODMAP diet, which is the standard of care, and it's effective. And she exercised, did yoga, and everything. Peg and peppermint oil were added as a subsequent visit. And then she said her bowel frequency did improve, but she's just having a lot of discomfort, right? Amal told us discomfort is one of the diagnostic criteria for Rome-5 now. And she has bloating. So what do we give her next, right? Peppermint oil helps bloating. PEG helps the stool consistency, right? So now we go into what is the quality of the evidence. And this is based on meta-analysis that have looked at this. So PEG, for IBS-C is low quality of evidence, and that's because it does improve spontaneous bowel movements, but it doesn't actually improve abdominal pain. And it can cause bloating, right? Prebiotics and synbiotics. A lot of our patients take inulin or fiber, may take yogurt, right? They eat yogurt, thinking this is gonna help their constipation. The data here is very low. So there's very few studies on prebiotics and synbiotics. Probiotics, again, we discussed, it's a low quality of evidence, and there's really conflicting, controversial data because it depends on the type of bacteria, the amount of species, all very heterogeneous and different. Antispasmodics was also very low quality of evidence. It could relieve the postprandial pain though, right? So some of the patients do get relief, but it doesn't really help the chronic pain, right? We keep discussing this as a chronic condition. And does cause some adverse events, right? It can actually cause constipation. So we wouldn't choose this as a choice in IBS-C patient. Now, we're lucky because we have 4 FDA-approved IBS medications. When I was in fellowship, we only had 1. And now we have 4. As of 2008, we've had them come along, and the last one was tenapanor, which actually launched in 2022. And they do have different mechanisms of action. So lubiprostone is a type 2 chloride channel activator. And the dosage that we use, these are called security-gogs. And the dosage that we use is 8 micrograms twice a day. That's the dosage we use for IBS-C. And there are some side effects, nausea probably being the most common, diarrhea is another side effect. Linaclotide is a guanylate cyclase C receptor agonist, very similar to plecanatide that came after that. And there's 2 dosages. So there's 290 micrograms for adults, and it's once daily. And then there's the 145 micrograms once daily for actually now approved in children over the ages of 7. So the side effect is diarrhea, and then there are other side effects. Tenapanor came out again in 2022, and this is an inhibitor of, the sodium and proton exchanger. So what that means is that there is retention of sodium in the gut, and with that you have water secretion. And that's 50 milligrams twice a day, and the side effect being, again, diarrhea. So now we have some treatments, right? How do we position that against the osmotic laxatives, all the over-the-counter agents? Well, some of the therapies, as listed here by Darren and Satish Rao, help abdominal symptoms, right? So many of them will help the bowel symptoms. Everything is a yes here. Stool softeners, I would say just throw them out. Like, no on the stool softener, okay? No probiotics, stool softeners, no. But as far as the bowel symptoms, all of these improve bowel symptoms. However, the abdominal symptoms only, as far as the over-the-counter agents, only get better with soluble fiber, okay? Where the therapeutic agents shine is that they do also help those abdominal symptoms. And we're gonna talk about that further from evidence-based medicine and the studies that we have. So both retainagogues and secretagogues help those abdominal symptoms that our patients suffer from, right? So what's the data with secretagogues? Listed here, or I'm not gonna go through this exhaustingly, but the number needed to treat is listed here for lubiprostone, linaclotide, and plecanatide. But there are some differences between the lubiprostone, linaclotide, and plecanatide studies because the FDA endpoints were different. So for lubiprostone, an overall responder was defined as monthly responder for over 2 out of the 3 months, and that was having at least moderate relief for at least 4 out of the 4 weeks, or significant relief for 2 out of the 4 weeks, okay? And there was an improvement with number needed to treat of 12. With linaclotide, it was, statistically significant also versus placebo with primary responders, and these are patients that it was defined as over 30% reduction in the worst abdominal pain, right? So this was much more rigorous endpoint, and then also an increase in the complete spontaneous bowel movement by 1 from baseline. Similar to plecanatide, again, also with these 2 secretagogues, there was improvement with these guanylate cyclase C agonists over placebo. All right, but how about the abdominal symptoms, right? So looking more specifically at the abdominal symptoms of bloating, discomfort, and pain, we're looking here at change from baseline. So a negative score is actually good. The more negative, the better. You have at the bottom on each of these linaclotide, and then whether it improved the specific abdominal symptoms being the discomfort, the pain, and then the abdominal bloating. And you can see at about 2 weeks, you start seeing a little bit difference between placebo and linaclotide, and that is maintained over 12 weeks. So a lot of times, adherence to these medications is really important, right? That's what we all stress, because if they're not adherent, well, they're gonna have, digression of all of their symptoms, the bloating symptoms, the abdominal pain, and the discomfort. But you can see there is consistent improvement throughout all these weeks. And then with plecanatide, this was also looked at for bloating severity specifically and all the other abdominal pain symptoms, the CSBM, and you can see that the abdominal symptoms all improved, and this is based on 2 phase 3 randomized control trials, and there is, improvement even in the bloating, which bloating is, again, not part of Rome 5, but it is a very significant symptom that many of our patients will report and that they suffer from. In fact, I would say in patients even with functional bloating, a lot of those patients suffer from constipation, and that's why in the guidelines that we worked on with Dr. Grossman, we said, please ask about constipation or perhaps in some of your patients that you think may have overflow diarrhea, get a KUB and see if there's a fecal load, because we can treat the bloating with these constipation meds. So now we have listed here, again, overall responders, so the same FDA endpoints that we had for linaclotide and plecanatide, and we're looking at global response here. And so you can see that tenapanor had overall significant effect on the overall response as compared to placebo. And IBS-C symptoms, the global symptoms improved. So here, this is again change from baseline for over the 12 weeks of treatment period. This is the pooled population data, with again diarrhea being the most common adverse event that was reported, but the abdominal score improves, and in about 2 weeks is where you really start seeing a significant difference between tenapanor and placebo. Abdominal cramping, discomfort, pain, and bloating all improve. All right, and then this is important. This study really is a post hoc analysis and a composite responder rates that were looked at in patients with or without prior IBS-C medication. So they're looking at de novo or after secretagogue failures, right? This is a question that comes up a lot. If the patient has experience on secretagogues, should I put them on tenapanor? Well, there are different mechanisms of action for sure, but patients who had an experience on secretagogues still had significant improvement over placebo when they took tenapanor. And then patients that are naive and never took secretagogues also have improvement over placebo. So there is this clinical meaningful response in patients' symptoms on tenapanor as well. So we go back to the patient case. So now she's, again, diagnosed with IBS-C. She tried the over-the-counter, she's exercising, and you're providing the education and validating her symptoms. So after discussing with her, she agrees that she's gonna do linaclotide as her prescription therapy, and she's taking it once daily. Importantly, she's taking it before meals. So you do wanna make sure that they take linaclotide half an hour before meals. She's taken now for 4 weeks, and she says, yes, my constipation really got better. But then she's starting to now experience some cramping. So the abdominal cramping isn't getting better necessarily, and she's having some diarrhea. So obviously, she took it for 4 weeks. Now she stopped the drug, right? If something causes you more abdominal pain and you already have IBS-C, you're not gonna continue to take the drug. So tenapanor 50 milligrams twice daily is now initiated. At 4 months, she has 90% improvement on symptoms, including her abdominal pain symptoms. All right? So now we go to question for the panel. I'm gonna ask Amal and Darren, well, when do you guys now start neuromodulators? So let's say in this case, for example, or psychological therapy. So let's say in this case, the patient takes tenapanor and she is better, but not like, I realize that there's no cure, but she's not 50% better,
I think it's an important point, and I always like to say that, I get the advantage of living in an ivory tower, and I've got 6 phenomenal brain gut behavioral therapists within my division. So I always try to go drug-free before I go with either more central neuromodulators. I use the peripheral neuromodulators first line, like you just described, but the centrals get held at bay. This is really for my patients that have overlapping disorders, like Dr. Sharma mentioned. The patient who walks in with functional heartburn and dyspepsia and irritable bowel syndrome, but potentially other disorders, overlapping anxiety, depression. Then I always tell my patients these neuromodulators are like a GI shield. It's a single therapeutic that can really work along that brain-gut axis to block a lot of the different pain symptoms that are associated with these syndromes, because we do think that some of the mechanisms are similar. We look at mast cells, we look at hypereosinophilia, we look at loss of tight junctions, loss of the intestinal epithelial barrier. We see that in dyspepsia and in irritable bowel. So some of the mechanisms we're elucidating, we're seeing a lot, but it also comes down to the patient. And it comes down to the patient history, right? I tell everybody this: if somebody comes to my office, this young lady flared, the last 4 months the symptoms are worse. The question is why, right? So what if the patient says to you, well, the reason I'm worse the last 4 months is I'm under more stress and I lost one of my parents to cancer, okay? At that point, when I'm thinking about this individual, I'm not thinking, what pharmaceutical can I give this person? I'm thinking they've had a trauma, a stressor, and I'm gonna go more of a brain-gut behavioral route. Now, yeah, there may be symptoms that I need to treat with a peripheral neuromodulator, like one of the FDA-approved therapies, but I really try to take the history into account. Yeah. And again, I really try to use these behavioral therapies because I can before I go to the more central neuromodulators that we all have the ability to prescribe.
Mm-hmm. That's pretty comprehensive. That's a great approach. I think with a lot of patients, they have not only is trauma, but the trauma may be very distant, and they have just had a behavioral pattern that has kind of persisted with this that they can't get over. And then another thing is you'll talk to them and they're constantly thinking about their symptoms. So, or they may be catastrophizing about when they may flare. And if that attention is constantly going on, I feel like that central activation is constantly there. So those patients, I think, definitely have a need for behavioral therapy, and I'm blessed to have one, not six, but at least one with me. So I frequently use them for those kinds of patients.
Yeah, absolutely. I think those therapies are effective, and honestly, if you don't have to think of these lasts, right? So if you have a patient that has severe symptoms, and like Darren and Amal are saying, they have these other factors that are happening, whether it's OCD behavior, anxiety, lack of sleep, right? Like sleep patterns go along with IBS-C also, right? The insomnia is common. And so, you may want to give them trazodone or something to help them with their insomnia, because otherwise their gut is going to be disturbed during all these episodes. So you can combine, right? We always do augmentation therapy.
But don't forget, remember, when we're talking about the therapeutics that Baha mentioned, these are peripheral neuromodulators.
Yeah.
In a lot of these studies, what we've seen is that the bowel symptoms come first, and then the pain follows by a few weeks, 3 to 4 weeks difference for all of these medications. So you have to give the therapeutic the time to work. We know that they have to get more time to see the pain, discomfort, and bloating. And one of the things that was on those slides, if you looked at all those Kaplan-Meier curves, what's interesting is when you look at the tenapanor data or look at the linaclotide data from the AS3 studies, those curves kind of mirror each other, right? If you were to take those curves, the pain, discomfort, and bloating, and overlap them, they would overlap very well, which kind of hints that there's going to be some sort of singular entity that's responsible for all of these symptoms. And if you can target that peripherally, you may not have to go centrally.
Yeah, absolutely. All right, very good. So I'm going to now talk about the pharmacologic therapies, which we call central neuromodulators, right? So we've got the sodium channel blockers, which are also acting on the norepinephrine, serotonin, the anticholinergic, the TCAs, right? These oftentimes tend to be first line when we're treating pain. So for pain predominant, the guidelines do suggest if you have a patient with moderate to severe symptoms, you could initiate TCAs. But they do have these other sedating side effects and other side effects, so you do have to be cognizant of that. SSRIs, we also talked about. Now, some of these SSRIs can be used for upper gut issues, so functional, chest pain and others. But they are actually not really recommended for irritable bowel syndrome. And if you have a patient, though, with anxiety, right, so it's anxiety predominant or OCD, then SSRI may actually be a good idea. But guidelines do not recommend these agents because they don't help the global symptoms of IBS and the pain in IBS. SNRIs, there's not a lot of studies on SNRIs, but duloxetine, venlafaxine, duloxetine actually was studied in bloating. So there was a retrospective study that we talked about yesterday, specifically in bloating, and that retrospective study from Harvard showed that out of all the different agents that we have as central neuromodulators, that was actually the most helpful. But we have all these other agents. And so when pain is predominant in a patient with irritable bowel syndrome, that's an agent that you could also initiate if patient has side effects to TCAs, for example. But even without, right? So if you think that this is a patient that may benefit more from the anxiety, they have depression, combined, SNRIs are a really good choice. And then we have the noradrenaline and specific serotonergic antidepressants. And these are mirtazapine, which is actually one of my favorites. I treat a lot of functional dyspepsia and gastroparesis where there's a significant nausea as a symptom or weight loss. And mirtazapine can be really effective, I think, for those patients. We mentioned trazodone. Trazodone may be effective for patients that have, insomnia, stress, they're not able to sleep. So I think those other symptoms, disturbed sleep, can be very helpful, and others. So I think, again, you have these drugs, they're combined with prescription meds oftentimes, with many of our patients that really have those severe symptoms that you're not able to target. And then, I guess I can ask the panel again, how long do you guys give them? Because I think a question that often comes is like, okay, well, how long do you wait? I mean, when do you start tapering them off, right?
It's a good question. I mean, so I tell everybody usually 4 to 6 weeks, and I titrate. I start low. And to your point, the reason we don't recommend the SSRIs for IBS, the data is very poor, is because realistically, to improve pain and abdominal visceral sensory symptoms, you have to have both norepinephrine and serotonin. And so the tetravalent tricyclics like the mirtazapine, the SNRIs, the TCAs, they can do that. So I start low and I go slow. And I will use, for example, we take the TCAs, I'll start with 10 milligrams.
Yeah.
I'll use it for 2 weeks and I'll say, if you're doing better, we'll keep it there. If you're not, we'll increase it. I don't tell them that I don't expect the 10 milligrams not to work because then it doesn't work. I just tell them we can increase it. And I'll go about as high as, 50, in some rare cases, 100 milligrams. But I also use that to justify the fact that these are working kind of in the periphery as well along that brain-gut axis, because I mentioned that these are old school antidepressants. I address the elephant in the room and I tell people, but back then we used these in doses of 200, 300 milligrams, much higher doses than 10. And I tell people we changed the name from antidepressant to neuromodulator, just like when we first started using aspirins, we used them for inflammation, right? For joint pains and things. And now we use them for secondary prophylaxis of heart attacks and strokes. So with medicine over time, we learn how to retool therapeutics to our benefit. As medicine advances, we understand better what these medications are doing for us.
Yeah, and I think,
What about you?
sorry,
Yeah,
I was going to say that I think that the thresholds is a moving target too, right? I mean, I think you need an expectation set. Patients that there's no evidence because it's just so complicated. That pathophysiology side says certain foods may trigger the pain, certain other things that we don't know, lack of sleep. So there's so many factors that go into it, and moving the patient through all these therapies is trial and error. And sometimes it takes quite a time to find exactly the right dose or the right medicine that will work with behavioral therapy, with some of our medicines for IBS-C.
That's a good point, right?
Yeah.
Sometimes we mix them.
Yes.
So our behavioral therapist will actually come back to us and say, I'm controlling the catastrophization of the IBS symptoms, but there is a component that is just high anxiety that we can't treat. And they'll ask us to prescribe like an SSRI to reduce that component of the process as well. So there is that integrated piece where we use these medications along with behavioral medicine. That's a really good point.
Yep, absolutely. Great discussion. And then psychological therapies, right? Again, same here. We don't have to wait till much later in the treatment algorithm to initiate these, really gut-directed behavioral therapy, right? So if you're identifying the patient, like Amal was saying, the patient's catastrophizing, there's childhood trauma, there's a lot of PTSD, like veterans, for example, in one of the discussions at DDW, was, there's a lot of PTSD in some of these veterans, and so you may want to initiate some of these therapies with your prescription meds from the beginning, right? So that addresses that. Cognitive behavioral therapy, these are what we have available. Hypnotherapy, this multi-component psychological therapy, dynamic psychotherapy, right? These are all things that our psychologists can offer, and in places where you don't have a GI psychologist, because I acknowledge that not everybody does, but you have someone, a psychologist, that's interested in learning or can guide you and guide the patient towards, apps, right? There's a lot of apps like Calm and others that are web-based now that are available, and I think many patients are actually really open to them. They don't have to come in for this, right? So there's not time missed off from work. They can do these things after work. And then these digital gut-brain therapies that are available can be very effective for our patients. And I know the three of us probably, when we see our patients, you really utilize these therapies to really take care of our patients and make sure that we're addressing those other factors that they have mentioned as we're gathering all our data. And sometimes it doesn't, I would say, especially with regards to childhood trauma or sexual trauma and things like that, right? Those are very sensitive topics, and they don't often come up in the first, right, evaluation, in the first visit. So these are things you'll work through with subsequent visits, right? Something they'll open up as they see you and the patient-physician relationship has, progressed, right? They trust you, you develop trust, and they realize that you are invested in their care and you're trying different things to get them to that kind of 50% improvement or whatever the goal that you guys set. So yeah, I don't know if you guys have any comments about that.
Yeah, I just think I'd iterate the point. Again, look at the mechanism of action. If it's a trauma, again, this is where I think, unfortunately, Rome gets it a little bit wrong, where they say this would be a second-line intervention or a third-line intervention. That's because there haven't been any clinical trials that have looked at just using behavioral therapies without it being an adjunct. Even the IBS-OS study that we did years ago that looked at minimal contact CBT 4 weeks was an adjunct to standard therapies. But I will tell you, in clinical practice in 20 years and referring thousands of patients to our behavioral therapists, it absolutely is effective as a first-line agent in the right person with the right triggers.
Yeah, absolutely.
And then I would also say that the access is being increased because you can be at Northwestern MUSC Atrium and have a therapist by your side, but many places don't, and now they're available virtually and through apps and even VR and things like that, so that patients can have access to these treatments that are very, very necessary and sometimes even more limited than seeing the gastroenterologist. So I think that's the accessibility should only increase as we go forward.
Absolutely. I'm glad you mentioned VR. There were some really cool sessions that were on that at DDW about virtual reality and patients with functional dyspepsia and IBS. So. All right, very good. So back to Taryn, taking out in the streets again.
All right, it is my favorite part of the program, taking it to the streets, getting some audience impact. It is time to rove. Here is our next question. Let's serve up the next question to the audience so we can get a dialogue going with our doctors. The next question is, what factors do you take into account when formulating a treatment plan for IBS-C? The question once again, what factors do you take into account when formulating a treatment plan for IBS-C? I would love to rove around and see what some of our audience members have to say. And once again, get a conversation going between you all and our expert panel on stage. Raise your hand. Don't all raise your hands at once. Anyone like to share? Here's the question once again. What factors do you take into account when formulating a treatment plan for IBS-C? So for all the clinicians in the room, what factors do you take into account? I thought I saw this table looking at me.
Yes.
He's looking at me now. Would you like to contribute, sir? I think that's excellent. All right, hang on. Let's get our photographer set up. Are we getting a good frame? Okay, what's your name?
Richard.
Richard, it's lovely to meet you. I'm Taryn. I'm going to have you look this way. You can look at me. All right, so what are your thoughts? The question is, once again, what factors do you take into account when formulating a treatment plan for IBS-C?
So I'm looking at what the patient has access to. So insurance coverage, what could I get? If it is about getting some sort of additional help in, is it available in my area? If it is virtual, is that something the patient is willing to do, which sometimes is not always convenient for them, or they like just to say no. Right. It's something different. And where I live is more rural, so to get to a specialty place, we're talking about 2 hours away.
Right.
Yeah.
So it's a little bit harder. I have no psychologist within easy distance.
Where are you from?
Southwest Virginia.
All right.
So usually it's UVA or Wake Forest is who I send most people to.
Yeah, but access, very, very, very important. Well, thank you so much, Richard. We really appreciate your participation and for roving. I hope that was fun. Doctors, what do you think of Richard's answer?
I actually think it's a really good answer.
Yeah.
I mean, I always talk about the 4 C's. The first 2 are, unfortunately, in 2026, still the most important, which is cost and coverage, right? If the patient can't afford it, especially, if gas is $7.50 a gallon, it can be hard to be able to pay for these medications. So if they can't afford them, they're not going to get them.
Yeah.
If there's no coverage from insurance, it's not going to happen. And then there's comfort. Your comfort with prescribing these medications, the patient's comfort with taking them. You have to talk about the efficacy, safety, tolerability aspects of the medication, and then compliance, right? If you've got a once a day versus a 5 time a day therapeutic, there may be some compliance issues. Then there's the SDM, the shared decision making. You shouldn't be making this decision on your own anymore. No. We have to have appropriate conversations with our patients about what's available. They want a seat at the table. They want to be involved in this process, and they need to be part of the process when they say, I want to take this for this reason. And in many cases, if it's no better than the other therapeutics, we have to be comfortable giving it to them if we can, under the auspices of what we're allowed to do, from a pharma standpoint. So I really agree.
That's awesome.
Yeah.
No.
Yeah, I think the diarrhea, when you talk about patients' diarrhea, I sometimes say that in the clinical trials, they have a couple loose bowel movements that's marked as diarrhea, so it may be overstated, and that might be a relief to you. So emphasizing that, there may be a tolerability aspect that's overstated in the adverse events.
Yeah, I think that's a great point. So, we're going to finish up our discussions today a little bit with how we individualize treatment for IBS-C. And I think this is really important because at the end of the day, we can talk prescription medications, we can make diagnoses, we can address trauma, which can be very difficult to do, especially at the first visit. But if we don't establish a good relationship with our patient, all bets are off. And we know that. And this is especially true in patients with disorders of gut-brain interaction. Most of these patients have some sort of other overlapping somatic comorbidity, anxiety, depression, at least at the academic level. So we have to be able to address these. We know that patients come in nervous. In my clinical practice, I'm giving 10th, 11th opinions. These people are frustrated. They've been through tests. They spent thousands of dollars. They've gone through numerous therapeutics and they're not doing better. And they just want to be heard. I get my chart messages all the time where my patients say, it's a laundry list. I mean, it is this long and it's 4 parts, but at the end of part 4, it says, thanks for listening. Okay, they don't know if I read it, and I do read these, but all they wanted to do was get it off their chest and realize that somebody can relate to that and can empathize with them and is going to be there for them. It is a major portion of what we do in the world of DGBIs. And that relationship is key. There are numerous studies that have shown if you validate the symptoms, forget the, I think it's IBS. Use the criteria Dr. Sharma showed you. It's IBS. I'm going to tell you that. It's irritable bowel syndrome. Doesn't go any further. Empathize with it. I know how you feel about this. I know what you've been through. I hear it all the time. Some of us may even have irritable bowel syndrome and can relate personally to that sort of thing because we want to reduce healthcare seeking. We all know what happens. You go to the next practitioner, they do more tests. You run enough tests, something's going to come back positive. And that person ends up with their 10th EGD or in an operating room or with a treatment that makes absolutely no sense to their symptom profile because we just went through the litany of every test we can run in something. If you run 100 tests, it's going to come back positive at some point. If you have that negative relationship, you blow them off, I think it's IBS, whatever, you're crazy, just go learn to live with it, get out of my office, I don't have time to talk to you, I want to go do another procedure, then the patients are going to leave, okay? We're not doing them the service that they asked us for. And again, I say this all the time. As GI practitioners, we know disorders of gut-brain interaction are the most common things we see. We have asked for this. Patients didn't ask for their symptoms or their profiles or the reductions in their quality of life, but going into GI and picking the specialty, we asked to have to do this, and we have to have the commitment to our patients to get them better. And again, sometimes that's just listening to them and talking to them. So at the end of the day, you also have some other responsibilities. You have to set realistic goals. My patients come in, they say, Dr. Brenner, I waited 6 months to see you. I am so thrilled to be here. You're going to cure me. And I'm shaking their hand. I look at them and go, nope. I have no cure for these disorders, but I will do everything in my power to reduce your symptom illness and your burden and improve your quality of life. Be realistic up front because if you're not, you set expectations that are impossible for this patient population, okay? Explore barriers. We talked about therapeutics. If you can't get them, think about another option. Where else can you get them? What else is available? What else can we do for these patients? Is there something going on in another domain? Is there overlapping OB-GYN issues that we need to get our gynecologist involved with? Maybe there's overlapping endometriosis, chronic pelvic congestion syndrome, et cetera. Don't think about these disorders in just a singular vacuum. There can be overlapping syndromes that need to be treated and addressed as well. Encourage the questions. If we really know what we're doing, we should allow the patients to ask the questions. I say anything else, anything else, anything else. The patients are nervous. If they're alone, sometimes they hear nothing. All they want to hear is, I don't have cancer. They'll ask, can I tape the visit? 100%. Bring out your phone, hit record. I want you to hear what you need to hear, and I want to answer what you need to know about to make you comfortable. We've all seen this. If you do a good job, you may prescribe nothing after that initial visit, and the patient will say to you, I already feel better because I have hope and because you're listening to me and you validated that this is real. That's all you need to do to get a lot of these patients better. And like I said earlier, involve the patient in the decision-making process. The days are gone of paternalistic medicine. It's not script, come back in 3 months, script, come back in 3 months, and running this cycle. That's when patients leave. They want a seat at the table, like I said before, in their own personal care. And then you have to use their frame of reference. If you go in and you say, this is a disorder of brain-gut interaction, which has visceral hypersensitivity and a lack of intestinal epithelial barrier, which is leading to abnormalities along the trochus, blah, 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 you've lost them. You have issues in your gut, and your gut's not happy, and it sends a signal to your brain, and your brain gets the signal and says, I understand what you're saying, and it sends a signal back down to the gut that says you're in pain. And maybe sometimes that signal is hyper-exaggerated. What is causing pain in you doesn't cause pain in the person next to you. But guess what? It causes pain in you, and we have to figure out why and how to treat it. Put it in very simplistic terms that the individuals can understand, and that's going to get you much further than before. At the end of the day, we know there have been multiple trials. Interdisciplinary, multi-specialty care is really important. And we talk all about us as practitioners in GI, we talk about our behavioral therapists, we talk about our dietitians, but who are we kidding? Who's the first line? Our nurses. They take the calls, they facilitate. They have to be trained to be kind and compassionate too. They have to have an idea of what we're looking for and how to address the patient's symptoms. And if they can't, then get the right message to us so we can take over from there. But every part of our practice is a member of this team that integrates and interacts with that patient, and that's only going to make things beneficial. And this is just one of many studies that has shown, if you look from a global symptom improvement standpoint, or you look from a validated scale standpoint, the IBS-SSS, 50-point reductions are clinically meaningful and significant. Interdisciplinary care, as opposed to standard care, always gets patients better and has been shown to reduce economic burden in terms of testing in the levels of thousands, okay? And in this clinical trial, it was about 2,000. So let's go back to what I said earlier. About 40 million people in the IBS, with IBS in the United States. If we do this 40 million times 2,000, how much money is that to spend elsewhere on other disorders where we need to do more aggressive testing to get these people better, or potentially treatments, cancer treatments that will cure people? That's where this money is better spent. So at the end of the day, what can all of us tell you about irritable bowel syndrome? Well, we know it's a disorder of gut-brain interaction with a complex biopsychosocial process. I love IBS. You will never see us write an algorithm in an IBS guideline because you can't. IBS is an N of 1 disorder, okay? Everybody that walks in the door is walking in with a different type of IBS, and that's what makes it so exciting, because you have to tease through that and figure out what is causing the problem and how you're going to treat it. Okay? But that being said, if you want to make the initial diagnosis before you dive deeper, use the Rome 5 criteria. We didn't talk about this, but in IBS-C, if you take the inclusion criteria of Rome and the alarm signs or symptoms, if your patients don't meet them, the accuracy of an IBS diagnosis approaches about 95%. Okay? We don't need a lot of tests. So tests are selective. On the C side, none. On the D side, serum IgA, tissue transglutaminase IgA to rule out celiac, and a fecal calprotectin or CRP to potentially rule out inflammatory bowel disease. That's it. We have lots of medications for IBS-C that are FDA approved. We talked about the secretagogues and the retainagogues, which have a little bit different mechanism of action. You want to talk to your patients about these and see what their thoughts are when you're thinking about prescribing these. The over-the-counter prescriptions, I'm not a fan. Remember, the sine qua non of IBS is pain and discomfort now. Rome 5 did Rome 3 a disservice. It was better clinically. I'm thrilled that we shifted back and we got away from Rome 4. But the over-the-counter laxatives and antidiarrheals will not get the abdominal symptoms. I'm not a fan of using polypharmacy when I've got good evidence-based therapeutics through rigorous phase 3 and 4 trials that show that with a single therapeutic, I can get you better. I can get the global symptoms, so I go there. And remember, use your colleagues and use shared decision-making for the best outcomes.
A big round of applause to everybody. First and foremost, to our expert panel of doctors, thank you so much for being here. We couldn't have done it without your incredible insight. Have to thank our incredible audience for your questions, of course, and to my roving reportees. Thank you so much for participating. Round of applause. This was great. To be continued. We'll see you next time. Thank you. Thanks for being a part of our news report.